Dr. Todd, earlier you had told me that you had grown up in Pennsylvania.
Yes.
I wonder if you'd describe a bit. You were born in Philadelphia, you said?
Born in Philadelphia, a
And
comfortable family until 1929 when my father was bankrupt and our 1930s were a disaster.
Yeah.
When I finished high school, my father was ill and unemployed, and I went to work as a machinist.
He was an engineer himself, though.
He had a small engineering company, did all mechanical engineering. And when he went bankrupt, they repossessed the home, his 2 cars, all the decent furniture, and we had to be distributed among relatives. So the 30s were tough, and it delayed my getting into college considerably.
But you grew up in Harrisburg. And
no, I just finished. My father had a 1-year job in
just
Harrisburg.
1 year in Harrisburg.
I graduated from high school in Harrisburg, that's all.
And after the war, then you went to Temple University.
Yes.
That must have been difficult at that time, except I suppose that was on the GI Bill from your service in
I was on the
World War
GI
II.
Bill, and I had a little business cleaning furniture, rugs and furniture.
I wonder if you might tell us something about the experiences you had in World War II and that appear to have influenced your decision to enter medicine.
Well, I had been trained as a drill sergeant, and I went to Medical Administrative Corps school, and while I was there, a directive came down that everyone who didn't have 2 years of college had to be dropped because they were oversubscribed. So I left there as a tech sergeant, which was the same as a first sergeant, then 3 stripes up and 2 down, as a reconnaissance for the medical battalion that was going overseas. We landed in Oran and were passed up to City Belabes for the Foreign Legion as for our preparation while Sicily was being overrun. And then we were there the first day when they invaded, I think it was the 23rd of September, 43. We went into the Straits of Messina, into Italy, then walked all the way up through Calabrese as the Germans retreated. They were far ahead of us, and it took us until the 15th of December to reach Naples. And from there, it was just one campaign after another, Anzio, Monte Cassino, on up above Rome to Bologna and the Po Valley.
But before then, you had mentioned the casualties that you saw.
Yes.
In both Anzio and then later at Monte Cassino.
Yes. My job was to locate a battalion aid station behind whatever battalion was fighting, and then evacuate patients back to a field hospital. We didn't have MASH in those days. And I was, as I told you, I was the least likely person to become a doctor. I threw up and felt faint every time I saw blood or a bone sticking out. But you get over that because you know something has to be done for these people. So as I would take them back to the field hospitals, the young doctors there taught me how to put the Thompson leg splints and arm splints on, and eventually taught me how to first put big sutures in to control bleeding and things. But it became more and more delicate, and the next thing I knew, I was terribly hooked.
And you were performing services much like those of a medic then in the field?
There were no doctors in the front lines. The first doctor and nurse you saw was in a field hospital.
But I mean, you were serving more or less like a medic then?
Yes, I wasn't one of the technicians that were supposed to be taking care of people. I was supposed to be evacuating.
I understand.
Yes.
But you said earlier that you had been given the suture kit. And
yeah, oh, yes. The young doctors were very helpful in that respect. Anybody they saw who could help bring the patients in better shape, yes.
Do you believe that was the primary impetus for you to decide to enter medical school?
Oh, yes. I had, when I'd go back, as I was bringing the patients in much better shape, I made more and more friends among doctors, and they were very encouraging. I picked up all kinds of instruments and medical supplies and things just out of their kindness. yes.
Even when you went enrolled in Temple University, did you already at that time know that you intended to be a doctor?
Yes.
Mm-hmm.
I knew that, but I also had been reading a great deal, and I wanted to major in English, which I did. And I was able to get all the requirements I needed to get into medical school.
As an aside, so often the pre-medical curriculum is rather rigid and not doesn't permit pre-medical students the latitude to take more than a few electives in non-pre-medical subjects. Was that true at that time?
Well, they let you take what you could handle, and if you took too much, you flunked out. But I doubled up, and I got through in 2.5 years. And
a bachelor's degree in 2.5?
Yes.
That's going summers, though, too.
Yes, steady, right on through. Yes.
Had you had a long-standing interest in literature?
Yes, my father had a good literary background, but he encouraged me to read. He didn't push me into Latin and Greek where I would like to have been pushed, because he was fluent in Latin and knowledgeable in Greek. You
had told me earlier as well that he had received education in St. Louis, I think.
No,
am I mistaken?
His father
or his
married an English girl who was teaching Latin and Greek in St. Louis, and the county sent him back to court her and bring her back because they needed a school teacher.
I see.
And this was prearranged, and when he got to meet her, she liked him, and he liked her, and she came back and became the school teacher.
And your father's education then?
My father's education in Latin and Greek, as well as the Bible, began at about 4, and they got rapped over the knuckles or beat across the backside if they didn't have their lessons done. Very young age.
At home or school?
At home and school.
And
I don't mean that they were abused because they never got hit in the face or anything like that, but
sure,
it was a Methodist community and it was very stern.
Your interest in literature remained, has endured over the years, but subsequently, many years later, you took a master's in liberal arts.
Yes, at
USC, and as well a doctorate degree at UCLA in history in 1981.
Yes.
That's a bit unusual for most neurosurgeons or doctors in general.
Not for a young man who had been kicked out of officer school because he didn't have the required educational background. That burned like a poker. And I guess it's a sort of scar you carry all of your life. And besides, during the service, I read every time I got a chance, and so English was a very easy subject for me, and it made it, I could breeze through English, and this enabled me to handle the tougher chemistry and physics and things required for medical school. They eliminated you in those days on chemistry and physics, yes.
As well, you had taken a degree in law from Loyola University in 1975.
Yes.
What were your primary reasons for doing that?
Well, I didn't understand the legal system. I didn't understand how malpractice was mounting. I saw the fickle cases accumulating, and it was sort of out of disgust. I wanted to see what was making this happen. And so I went through and got my degree, and I learned.
Do you feel that there's any particular remedies that seem feasible at the present time?
There are a lot of remedies that are feasible, but they're unsurmountable. The most potent lobby in this country is the American Bar Association. And of course, there's a way to change it. Like other countries, when you become a legislator or a judge, you should give up your membership in the Bar Association. And then if you don't get elected and you go back, you have to take it all over again.
Do you feel most of it comes from the American Bar or the American Trial Lawyers Association?
Well, the trial lawyers influence in the Bar Association. They're a very, very powerful group. Trial lawyers, general, criminal, and civil.
How would you recommend that instances be managed not involving tort law to both investigate and also determine whether or not there was any merit in a particular instance of a bad outcome, say?
Well, we're getting out to where I have no expertise, but I've always felt that there should be arbitration of some form, not only in medical cases, but in car accidents and things of that nature. But there's no way you're going to beat the trial lawyers out of that. They're too powerful.
Sure.
But, I mean, a very simple solution, but simple solutions are impossible to accomplish.
And most legislators today are also lawyers.
All 90%, 95%,
Yes.
some legislatures.
Then you went to medical school at Hanneman, and on your completion there, you went to Seaside Memorial Hospital in Long Beach.
Yes.
And you had said earlier that it was while you were serving that internship that you first became exposed really to neuro research.
Yes.
And Dr. French and Dr. Magoon, and in particular their work, that led you to decide to enter neurosurgery.
Yes, I had wanted to be a cardiac surgeon. As a student, I had worked with Charles Bailey developing intraatrial defects, and a couple of weeks later, after the dog healed, he would go back and attempt different methods of treating it. And I was thrilled with the research and planned to go on. When I got to Long Beach, I was looking to see what was going on in the area, and the exciting thing in the area was what French and Magoon were doing. And
what were they doing at that time?
well, nobody really knew what they were doing. They just told me that they got a lot of spikes sticking out of monkeys. Well, I knew that they had implanted electrodes, and so the VA, what had been the Navy hospital, became the VA hospital, and they would have a regular neurology program, and Magoon or French would often show up for that. And this is where I met them. They let me come back and see their animals. As I would hang around more and more, they found me less and less of a nuisance. And when I told them that I liked what they were doing so much, I was going into neurosurgery, and that I planned to go up to USC, LA County, French said, no, I think you should go someplace where you got a wide, broad, balanced training. Then you'll know better what you want to do when you come out. You'll be so busy with trauma at the LA County, you won't have time for research or anything else. So French called Jim Gardner and told him that he had a young man with 3 kids, and he knew that he didn't like kids, but that my wife it was acceptable to her. It was more important to her that I got a very good residency. So
that was in June of '54. You commenced your residency in Cleveland.
Yes, we packed up our 3 children and got one of the U-Hauls and plowed across to Cleveland. Yes.
What was Dr. Gardner like personally, and just briefly, as well as your chief of service?
Well, he was a fine, honest, hardworking man, and he demanded that everybody else be hardworking. He interviewed the wives before he came on the surface and said, "You're not going to see your husband." We were only allowed out 2 nights a week, and there were people who snuck out. And if he would understand, well, the man has children, he wants to get home, but we can't use them. And so he would see that they got a residency someplace, and there was a flow to Iowa and Chicago of residents who it was just impossible to keep up with a schedule like that. And, but he was a good-hearted man.
Did he take a personal interest in the residents?
He took a very personal interest. He knew everything that was going on. Jim Gardner got up at 5 o'clock in the morning, had a black cup of coffee, and then did his reading and writing. And at about 5 minutes to 7, he took off for the tennis court in the summer and the ice skating rink in the winter. You know, he raised 2 Olympic gold medal
No, I didn't know that.
champions. They came from a broken home, I think it was down in Columbus, and he brought them up and raised them. And they became, both won gold medals in men's singles.
What were some of his outside interests?
His outside interests were ice skating, hunting. He would go hunting every year for a week down in Texas with some of his ex-residents. He was a hiker, a very vigorous man who kept trim all the time, ate properly, and worked very hard. Every morning at 8 o'clock, all the residents were up on the 8th floor waiting for the elevator, and at 8 o'clock, it wasn't 8:02 ever, maybe 1 or 2 minutes before, but never late. He stepped off and we started his enormous load. He did an average, I would say, of about 5 or 6 surgeries every afternoon, 5 days a week. And often had 2 or 3 rooms going where his residents were. The senior resident could do anything he wanted so long as he could handle it. And if he took more than he could handle, he would be cut back sharply. But he knew pretty well what they could handle, and if he looked like they were taking on an aneurysm or an 8th nerve tumor or something that might be a little bit too much, he lurked in the background and satisfied himself that the man could handle it, because he wanted them to be able to handle anything when they left there.
The residents trained by Dr. Gardner were essentially trained with the idea that they would enter private and general neurosurgical practice, do you think? Or?
I think generally, but he was also looking for scholarship. When you come from a clinic, you don't have the university connection, but he still wanted to see his people get into research.
Did you all have a chance to participate in research while you were there?
Yes. We were all encouraged to take a half a year or a year at some very leading institution. And Don Doan, who was contemporary with me, took a Fulbright scholarship to Queen Square in neuropathology. And I took my half year with Louise Eisenhardt at Yale, and as a preceptor.
In neuropathology,
yes, and Gardner, when he insisted when you went there that you went there and you worked the same way that you did at his place.
In what way did Dr. Eisenhardt teach you? Was it a one-to-one basis?
Well, she assigned me slides to go over, and while I'm going over the slides, she's back there. She was the editor of the Journal of Neurosurgery.
Yes.
And having been an English major, occasionally she would, if she thought it was a pretty good paper, before she sent it out to the editors, the co-editors, to get their views on it, she would ask me to see if I could fix up the paragraphing is clumsy or the spelling is bad. Will you correct the spelling and grammar? Because it was a good paper otherwise. But I never had anything to do with selection of the material.
But I meant after reviewing the slides, would she more or less give you a tray of slides and ask you or expect to have you review them, and then she would review them with you subsequently?
She would test me on them. As a matter of fact, there were a couple of Bill German's residents always hanging around, and there were always 3 or 4 people from all over just dropping in to use the Cushing collection, preparing for their boards.
I recall people telling me over the years that they would be very impressed, initially a bit overwhelmed by the gold and silver slides of tumors especially. And if they had not seen them prior to the board examination, it came as a bit of a shock.
Yes. While I was there, Ben Crew came through from the Navy. he was particularly interested in all of Cushing's posterior fossa tumors. He was preparing a book himself.
Yes.
And this is where we made our association, and it eventually led me to Hunter Sheldon and Bob Pudenz, because he was planning to join him when he finished the Navy.
While you were in New Haven, you also came to meet and know Dr. Fulton a bit.
Yes.
What was he like in those years?
These were years when he was sick and in rapid decline.
Was he still writing a fair bit?
He wasn't writing, but he was giving regular lectures in the history of medicine. It was amazing. He would always take rare books down to whatever he was talking about, and he knew where everything was. His mind had all of this set, and he could quickly, he'd give me a list of things to get, and I'd get halfway through them, and he'd come in and he'd just go whizzing around, finishing it out, and I'd carry the books down. And in the middle of his talks, he would lose his train. And I found that the good thing to do was to get his notes so that if he got puzzled, then he would walk back and forth trying to get back on train. And I'd whisper something from the notes. So he was, as Louise Eisenhart watched him declining, she would tell me that he had the most photographic mind of any man she had ever known. So it was a painful thing for her to watch this.
Sure.
Now, I was sent over every day at noon to pick up Dr. Fulton and Dr. Sachs. Dr. Sachs had had a stroke that didn't affect him mentally at all. He was sharp and clear as a bell writing his memoirs.
How did, by the way, he happened to go from St. Louis to Yale for those several years?
Well, he was getting old. He'd had a little stroke,
Sure.
and they were looking for articulate people like that to for their history of medicine. But actually, he would introduce speakers, but I don't remember him lecturing. He was writing his memoirs all the time.
Was there any reason you were aware of that he chose to go to New Haven rather than, say, Princeton or some other
I think it was
institution?
by invitation, because they were sort of accumulating people like Fulton, and they felt honored to have them there and give them a place to work. And I believe that was probably it. They were really reaching out for things like that.
Now, you spent a full year there?
No, just a half year.
Just a half year, following which you received that NIH fellowship?
Yes.
And that was to the University of Edinburgh.
Well, it was a choice. At first I was going to join Pennybacker at Oxford, but John Gillingham came through and thoroughly charmed me and turned it around, because I had a choice of English-speaking places. The only other language I had was Italian, and there weren't any outstanding places in Italy at the time, and I thought the prospect of, I also, Wiley McKissick had accepted me at St. George, I believe it was. And so after Gillingham came, well, I was sold on Edinburgh.
Where did you meet Professor Gillingham?
He was a visitor at the Cleveland Clinic.
Oh, okay.
He was there for about a week with staying with Jim Gardner.
I wonder if you'd relate a bit about your experiences in Edinburgh with Professor Dott and Professor Gillingham and some of the visitors who came through, like you mentioned Dr. Kendall had visited there.
Yes, I got to meet everybody who came through, because I was the only American at the Royal Infirmary at that time. As a matter of fact, when the American College of Surgeons came through and all of the heavyweights came in, Rabden, Cole, Loyal Davis, Sir Robert Bruce called Norman Dott and said, "Send that American up." And I walked in my scrub suit. He said, well, he's scrubbed in. He said, well, send him up in a scrub suit anyhow. I walked in, and he introduced me to all these people, and they said, introduced me like, this is your compatriot, Dr. Todd, as though they should know me. And I'm tongue-tied at who I'm being introduced to. And it was quite an experience. But I would meet everybody that came through, being the lone American.
What was Professor Dott like as an individual again, and in surgery? Was he sort of remote, or was he also very much interested in his individual registrars, I assume, and assistant registrars, fellows and all?
Dot, he heard and knew everything that was going on. He said very little. He was a quiet man, and he was a good man, a pleasant man. Every night he would get the report on all the patients, and you would string out each case how it was doing, and there was a silence, and you only answered the question that he asked, because his mind was like a computer. He's putting everything into place. And then there would be a long pause, a very long pause. It might be 5 minutes that you're holding on to the telephone. Your hands are getting numb, and all this time.
Oh, this would be by phone now.
Yes, and all this time, he's going, reflecting over everything you said. Then he would come back after thinking about it and say, I want this, I want that, I want that. And he had heard every word you said. So you had to be very careful, very thorough. And this is the way his mind operated.
Were there any formal social contacts the registrars and all had on his service with him and his wife?
Yes. He invited us out to his house a couple times a year, and he took my wife and I as his guests when the British Neurosurgical Society had their annual meeting. Well, this year it was with the Netherlands. And so my wife and I were the guest. I remember I was sitting right in the front seat with him on the bus, and General Sperling came along, and would you mind? So I had to get out, and because they had been apparently together with Cushing.
Yes.
It reminded me also when Norman Dott came and visited with me and stayed at my home for a couple of weeks in California, Tracy Putnam dropped in. They had also been together with Cushing in Boston.
Now, in surgery, you mentioned that Dr. Dott was quite meticulous in his surgery, and
very slow and meticulous.
Slow as well, and that he was utilizing the transfemoidal approach to hypophysectomy. And I assume that he had never really switched over like Dr. Cushing had to a transcranial approach.
No, he never did.
But
that had been his.
To use Dr. Cushing's older approach.
He was. That was his primary interest when he went with Cushing, the pituitary, and.
Did he make any significant modifications to Dr. Cushing's older approach of hypophysectomy?
Yes, he modified the approach a little bit. He also made his own equipment. Norman Dott was the kind of man who wanted every instrument to fit precisely, and he would have somebody make them for him. And as a matter of fact, he made up this huge tub of retractors. I still have, Ben Crew is using that tub now. It was effective. He had it for all kinds of uses.
I remember the flexible copper shafted aneurysm ligature carriers that I think a one-man company made for him outside of Edinburgh. I recall one story, which is not part of this interview, but you mentioned one earlier as well, involving Professor Dott in surgery, where he was less than precise in what he asked one of the assistants to do with cautery.
No, he was precise, but as he worked away very slowly, it would be maybe 10-minute breaks before the resident would do anything. And Robin Lowe fell asleep, and the cautery came down right on Professor Dott's nose. He was really shocked, but he had a sense of humor too. He didn't make any kind of fuss, but when he went out of there, he was really grinning, they said. Well, the nurses were almost bursting. And he was aware, and when he went out, they said his eyes were twinkling. Lowe was scared to death.
You had mentioned as well that you had met Sir Jeffrey Jefferson several times.
I don't know, several times at the British neurosurgeons meeting. I had met him in 1956 in Detroit at a symposium, I believe it was on the trigeminal nerve, and he was the moderator of the program.
As I recall, I may be mistaken on this point, but I think he was the first honored guest of the Congress of Neurological Surgeons. And what I've been told about him is that he also was a very gentle person and a very gentle man.
He was a gentle, charming, very articulate man, and he spoke beautifully. And as I mentioned, it just seemed to me that John Gillingham was his natural. It was when Sir Jeffrey Jefferson died, Gillingham moved right into his shoes. The same charm, the same command, the same poise on the stage, the same presence. Yes, very much so. Now, you were wondering what he looked like. He looked like a lot like his son Anthony, who became a neurosurgeon.
Oh, I didn't know that.
Yes, yes.
But his influence on British neurosurgery was considerable.
Oh, yes.
But where had he trained in turn and developed his interest in neurosurgery?
I don't know where he trained. I know that during, first place I can pick up for you, during the war, Sir Hugh Cairns became the general who went over with the troops. So Jeffrey Jefferson took care of all the wounded being evacuated. Norman Dott had charge of domestic neurosurgery. That's the way they split it up.
And then on your return from that year, well, before you returned, actually, you went down to Queen Square, the National Hospital.
Yes.
And spent some weeks.
Yes.
Was that primarily just to learn more about their own approach toward clinical neurology?
It was something Norman Dott suggested. He had taken me down and to Queen Square. I believe it's Blackwood, the pathologist, was a former pupil of his. And we had dined together, and he suggested you should get a taste of this place. So much of British neurology and neurosurgery has come out of here. But they didn't take clinical clerks on for any of the services if you're only going to be there 4 to 6 weeks, as I was. So he sent me in to see Sir Charles Simons to see what they could assign me to keep me occupied. And Professor Carmichael was sitting there. And I left there with him and made rounds with him every day. And they sort of let me wander around, and I did some clinical clerk work. And for my little over a month there, I still feel like I'm a part of the group. And when Congress had the joint meeting a couple of years ago, I went back to see it for the last time because it was all coming down.
One thing from having known 2 doctors who trained fully in neurology there, was the great emphasis placed on a thorough neurological examination.
Very thorough.
And do you feel, this is almost rhetorical, do you feel that contrast studies and all have largely replaced the need of that thoroughness?
I don't think it's replaced the need. They use all the senses there, but it's become the substitute for the smell. The senses aren't as highly developed, I don't believe, anymore, because there was a conditioning process at places like Queen Square. And at Royal Infirmary, for instance, if somebody had a wound, if an incision became infected, the nurses could pick it up and smell and tell you whether it was staph or strep or a fungus. And they had been trained so that in women's diseases, they would just pick up the pad and smell, and they knew what to order for it. It was just remarkable. But I tried it, and I never did get onto it, just as I never got onto the technique of seeing in stereo. They taught me how to use my thumb, and I could do that, and it would go in and out, but they stood there with the two pictures up, and I believe there's a 6-degree change in angulation, and Gillingham and all of the radiologists and Dot, they would study them. Then I had to take them over and put them on that big machine, you know, with the big wheels.
Yes, I remember.
But I never understood why stereo angiography didn't take in this country. It was so clear in AV malformations where all the feeders were coming through. When you're looking at it in stereo, they had this huge, big iron machine there with large wheels, like it was like a printing press. You put your two pictures in, and you brought them into focus, and you're looking into this.
Yes.
And they wouldn't think of attacking an aneurysm or an AV malformation, but it never became popular in this country.
Which just reminded me of Professor Dott's first encounter with an aneurysm. Do you recall that?
That was back in about 1931,
yes,
I think.
Yes, long before, of course. But,
yes, I think that was the first aneurysm ever described by angiography,
yes.
And then successfully attacked on the basis of what the angiogram had demonstrated.
Yes.
Yes.
Whereas Nandy's was encountered, as I recall, by accident, really, and operated upon successfully by him, I think.
Yes, I'd forgotten about that. I hadn't even thought of that since I left Edinburgh in '57, but
it was just
I had seen that paper, yes.
On your return then from the United Kingdom, you went then to California.
Directly to join Hunter Sheldon and Bob Pudenz. We were also awaiting the return of Ben Crew when he finished the Navy. When Ben finished, he joined us, and we formed a four-way partnership.
You mentioned already, though, that there was a research foundation established there by Dr. Pudenz and Dr. Sheldon.
Yes.
Primarily directed towards the treatment of hydrocephalus.
No, it was widespread. They had a regular dog laboratory. They were doing a number of things. They were experimenting with all kinds of implants of silicone and Teflon. And when I joined them, I simply took up what they were doing and became known as Burr-Hole Button Todd, because I developed in place of wiring or other ways of fixing the craniotomy, I used the Burr-Hole buttons,
yes,
and never knowing it was going to become a nickname.
And during those early, well, the first year or so, did you once again become involved in research?
Yes, we had a number of projects. I took the silicone in a liquid form and used it to cover aneurysms. This was before microsurgery. When microsurgery came along, it was no longer necessary to do that. But the most effective way that I had of using the silicone was to use little strips of gauze, as you would put a cast on a broken leg, and I would wrap that around the aneurysms, and that took very well. And also, unlike the methyl methacrylate that I had, Philip Harris in 1957 used it, and I was his assistant on the case. And after that, we did it a number of times. Someone else in England had done it first, and Philip had gotten his supply. The methyl methacrylate came from a dentist who was using it for false teeth. But when I came back here and found him working with silicone, I found a silicone product, but when the catalyst was added, it quickly hardened.
Did it generate much heat, the silicone?
No. I never saw any damage from it. I put my finger in it all the time while it was forming. And when it reaches a certain consistency, that's when you put it on. But when I took it to Poppin at Boston, the catalyst had gotten a leak in it, and it was totally ineffective. And when Jim Poppin put that, it was like putting chocolate on a sundae. It just rolled down, and he really gave me the stare. But he laughed about it, and something's wrong with the catalyst. That never happened to me before. Oh, that was terrible.
But when was that, by the way?
That must have been about 1958, 59.
Very early on then.
Mm-hmm.
And your research into stereotactic procedures, when did that really commence?
Well, as soon as I got back, they had a number of Parkinson patients lined up. They knew that I had been doing this. I'd lost my instrument, and when they called Ted in, he sent young Rudy Schulte to work with me. And with Rudy, we developed these very primitive instruments that were quite effective if you knew what you were doing. And all we used was a protractor.
Well, earlier in Edinburgh, Professor Gillingham, he wasn't, I assume, a professor at that time, was he?
I think he was associate professor at that
associate
time.
professor, was doing the stereotactic work at Edinburgh, the Royal Infirmary, utilizing the gauze apparatus.
Yes.
And guide. And so it was quite a shift, wasn't it, from...
Well, he wouldn't let me use my little pocket instrument. I had to use the gauze instrument that I found very clumsy, and but that's all. If I was to do stereotaxy, I had to use that unit.
But the pocket instrument was the one that you'd used in residency at Cleveland Clinic.
Yes.
And then, so this was...
Well, on just a couple of cases, because we had the Cooper instrument, and I didn't think all that gadgetry, which was much simpler than other units like the unit that Weisses and Spiegel were using, but I thought it just got down to the skill of the harpoonist. And as a matter of fact, the people who were doing it and had done a couple hundred were very, very skilled. But the problem was training, and you couldn't train a resident. It took 50 cases to become really skillful. And if I remember correctly, in our first 50 cases, we lost about 5, which is a horrible percentage.
Yes.
Yes.
Of what? From what?
Parkinsonism.
No, I mean deaths due to what?
Well,
All cords?
hemorrhage, but a couple of them were infection. And the problem was that we were operating on people 85. We were just taking, in the beginning, we were just taking anybody who had Parkinsonism.
So it might have been a myocardial infarct or...
Could have been, it could have been a stroke. They stroked out, but the 5 of them died, and I can remember 2 at least that became infected. And
in California, though, were you had you commenced to use an atlas?
No, I didn't think.
You did use ventriculography, though.
I was always convinced that these atlases were totally ineffective in a human being. I know Ernie Sachs, when he was writing his memoirs, and he was telling me about Horsley Clark. They tried using dogs, but they was so variable that an atlas meant nothing. So they ended up with cats, and that's what he used for his. I'm pretty sure it was cats. Might have been monkeys, but I'm pretty sure it was cats, because it was the most consistent. In a human being, the ventricular system is as different as every human being is their face. And you have to have internal landmarks, because as I recall some of those early 80-year-old patients, they had huge ballooning ventricles, and the atlases meant nothing. What meant everything to us was getting a perfect demonstration of the third ventricle with the anterior and posterior commissures clearly outlined. And when you could draw a line from one to the other, they're usually about 25 or 26 millimeters. I think we held our tube about 8 foot out, and we would make our lesion in the thalamus for Parkinsonism. If it was 26 millimeters, it would be about 11 millimeters from the posterior. Then in our AP projection, it depended on the ventricle entirely, dropping a line from the ends and from the outer third, and in here is where we wanted to make our lesion.
Did you ever use electrical monitoring later on to help you identify placement of the electrodes in the globus thalamus?
It became apparent by 1960 that you can't train residents in this type of procedure. You had to have something where you could reduplicate lesions. And this is when Trent Wells drifted into my office one day. And it was also at the time that we were getting a radionics radio frequency unit.
Yes.
And for that we needed something stable, something that we could repeat our lesions on. And this is when Trent Wells and I worked on the instrument, first a portable and then a pedestal unit.
Which again was rather elaborate in size and refinement in the numbers of degrees of angulation and all.
You know, that's true, but what we did was we found a point in a room. We had a tube up in the ceiling and we had another tube in the wall, and where are these rays? And we were always being calibrated to make sure that they were coming together. It was that point in the room that the lesion was made, and we had an implanted, the pedestal was implanted, and these two were focused. Every time there was a little earthquake, we had to recheck it, but we would always collimate before we proceeded.
And the X-ray tubes were at a fixed distance. I think I remember the figure 3 meters to do away with magnification effects.
Yeah, well, it depended on where your wall was, but it was about that our wall happened to be. That's what, and the height of the room.
Did you ever utilize later on, though, something that Professor Guillot used or introduced, namely taking microelectrode recording, not microelectrode, but electrode recordings from the thalamus to help target his lesion, such as through more or less evoked potential by having someone stroke the thigh, the hairs on the leg, arm, and all that. Did you ever?
No, we didn't do that. We used a very low thermo current to see what it did to test, and if with a low blast we didn't accomplish anything, then we wondered about where we were, and we reviewed our X-rays to see where we wanted to move. In the light of every ventricular system being different, and where the way we visualized the thalamus and where we wanted to be in it, why are we not getting a response? And then we decided which way we would move, maybe 2 or 3 millimeters one way or another.
I recall some of the controversies at meetings, a few maintaining that it was necessary to produce at least some degree of paresis with the thalamic or palatal lesion in order to assure good result.
Well, I heard a lot of that argument, and as a matter of fact, Gillingham in the days when I was there thought that you had to put it in the internal capsule to get an effective lesion. I was satisfied to see a modification of the tremor or rigidity, and these were the only things I went after. I early learned that I could do nothing for speech, for akinesia, but tremor and rigidity were the two things that we could do something for, and sometimes at the expense of other things. It all depends on how much you were, how important it was, how bad this tremor and rigidity was.
Why do you think that speech has escaped the benefit of surgery, primarily surgery, though it often isn't affected appreciably by medication either?
I don't understand.
Well, in Parkinson's patients, why do you feel that speech posture would be very resistant to the effects of surgery that benefited, in particular, tremor, of course, but also to some degree or a large degree, rigidity of the limbs?
I always felt that it must be an akinesia aspect. There were cases that did improve, and I felt these were cases that probably had pharyngeal rigidity, laryngeal rigidity, and you were affected, but you didn't. They were rare. The opposite was often true. Their speech was worse when they came out of it. And sometimes we got this mild dysphasias on the left side.
Yes. Even
though we were far removed, but we must have been buzzing something up there and stunning the area.
Well, even Dr. Broca years ago, in one of those first 2 autopsied cases of his, in the One, the brain of Ton, that was discovered almost by accident when they were renovating the Dupuytren Museum. A CAT scan was performed on it, and Pierre Marie had been somewhat critical of Broca for not having dissected the brain, you know, sliced it. But Broca had studied pretty well on the interior without slicing it. And the CAT scan fit perfectly, or almost perfectly, the written description of Broca's findings, namely that there was extension into the corpus striatum and encroaching upon the internal capsule, which did not then conflict with Pierre Marie's later idea. But it's almost, I almost have had the feeling that Pierre Marie had not read Dr. Broca's description.
Well, I had seen a number of dysphasias. I use that in a British term, aphasia meaning complete, where the speech was affected for a while, but almost always that came back.
Yes.
We had, and I was just assuming that when we buzzed down there, we had stunned something, some reflection, because it was something that often lasted for days.
Now, another very great interest of yours was that in pain, the management of pain, and a number of your papers are devoted to that subject in chapters and texts. I wanted to ask a bit about the intracranial procedures that you performed for pain, particularly chronic pain.
Well, we did percutaneous trigeminal tractotomies. We also did the chordotomy. We did it from posteriorly. It was just a different angle when we were going up after the tract. And
how would you make those lesions?
We would make the lesion by AP and lateral films, and by our cadaver testing to put us into the, rather than any kind of an atlas, we had, Dr. Crew had done a number of cases at City of Hope where he had used the cadaver, and I believe it was either City of Hope or down at USC, because I never participated in the establishing precisely where the lesion was to be. He had done all of that either at USC or at City of Hope.
This utilized electrocoagulation?
Yes, and my job was to see that we got where he wanted to go, to get the electrode to that point. But he had done, you have to give him credit for all of the hard work in the anatomy lab and in the morgue on checking that out. But I always felt uncomfortable with tractotomies and chordotomies.
Why?
It just seemed jolting the patient in their brainstem was, I could feel it in myself as I did it. I would rather expose and see what I'm doing. And, but we did a number of cases, and then we backed off because...
Oh, you mean by percutaneous?
Yes, by percutaneous.
But by direct tractotomy and chordotomy, you felt differently?
Oh, yes.
Because you could see more accurately?
Yes. I never liked the stereotactic procedure, but we did a number and then we gave it up.
And singulotomy, I noticed you had done singulotomy.
Singulotomies were done on terminal patients with great pain. We served City of Hope in those days. We were the neurosurgeons for City of Hope. And what we saw from singulotomy, it didn't seem to improve their lifespan. And when you asked them, how's your pain? And they would always say, oh, it's the same, only they were socializing and having a good time and they weren't complaining. But if you asked them, they'd always say, oh, yes, I have the pain. Yes. It was like we did transsphenoidal hypophysectomies for bony metastases from prostatic and breast CA. And I was never convinced that we extended lifespans, although every once in a while there was a dramatic one where they would all disappear for a while. but it certainly eliminated the bone pain beautifully.
Yes, I wonder if you ever formed any ideas of your own about why the pain often would be dramatically relieved even on awakening from anesthesia, and why the relief often was sustained. I've never understood that.
I've never understood it.
I can rationalize the immediate effects might be from release of endorphins,
yes,
beta endorphin in particular.
We weren't on the endorphins at that time.
No,
and,
they weren't even
but
known.
I think that someone who's working with that could rationalize what we had done.
But the sustained relief, I don't understand.
Yes. They went on. I saw people maybe died in 3 or 4 months, and that's why I figured before the surgery, I figured looked like a case that didn't have more than 3 or 4 months. Yes. But the bone pain was gone, and that was the remarkable thing that I never understood.
I asked Bronson Ray that once and met with the same response.
See, I stopped doing it because I wasn't satisfied that we were extending lifespan, and but for prosthetic and for breast.
Improving the quality of life for these people.
Yes, after that, if I couldn't extend their lifespan, I'd rather put them on morphine. Once I get the opinion that, hey, in this condition, this is what I'd rather have, that's what I usually shifted to, and that's the way it was with these cancer patients.
This reminds me of something I forgot to mention earlier or ask about, and that was we had, before the interview commenced, spoke a bit about Professor Robotham in Newcastle.
Yes.
And in his book, I think in both editions, Injuries of the Brain or Head, he mentions the use of heroin for post-traumatic headache, post-concussion headache, which I remember even in the 50s was, to me, a novelty, because heroin, though accepted for medicinal use in the United Kingdom, was not approved, I don't believe, in the United States. Were you ever exposed to the use of heroin over there for the treatment of headaches?
No, I wasn't. I don't remember that in the book.
It stuck with me for some unknown reason.
That was the chief book used in the British Isles for head injury. And I used it while I was over there, so I was so happy to meet the man. And again, it's like one of those things where you shake hands and you're invited to come. And the only time I could get there, he only had a couple hours that morning, but so I saw Newcastle on time, mainly through his registrars.
Your primary work in stereotactic surgery has been directed toward involuntary movements?
Yes.
And any other areas?
We did amygdalotomies for uncontrollable seizures.
Bilateral by any chance?
No, I can't remember any that were bilateral. I do know that we had 2 kids about 18 or 19 years old with intractable seizures and severe headaches, and the surgery was very effective. The problem was that Dr. Crew always scheduled them to come into his office to see him at the same time. These kids fell in love and got married. Crew has followed them along. I don't know how the offspring turned out.
And what type of headaches were they?
Well, they were headaches from one from birth injury and the other from a severe car accident.
I see.
Yes.
Relieved by amygdalectomy?
Well, these are where they had pinched off, where there had been brain swelling. They had damaged the mesial aspect of the temporal lobe. We got a unilateral focus.
Yes.
I mean, our criteria depended upon a very strong unilateral focus of implanted electrodes.
Did you ever have occasion to do amygdalotomy, selective amygdalotomy, on patients who demonstrated episodic violent behavior and who had spike discharges demonstrable on EEG?
No, but we were planning to do so. there was a surgeon using our instrument on the west side, Hunter Brown, I think